Hello, everyone. Welcome to this virtual tumor board. It's a pleasure to bring together international faculty to discuss these cases. Before we get started, we'll just do a round of introductions. I'm Dr. Benjamin Levy, and I'm Associate Professor at Johns Hopkins School of Medicine, a thoracic medical oncologist. I am joined here today by, again, a fabulous international group of physician scientists. We'll start with Dr. Sanjeev Bala. You want to introduce yourself, Dr. Bala?
Yes, hello everyone. My name is Sanjeev Bala and I run the cardiothoracic radiology division here at the Mallinckrodt Institute of Radiology at WashU in St. Louis. Nice to be here.
My name's Wally Kern. I'm the executive director of Winship Cancer Institute here at Emory University and chair of the Department of Radiation Oncology.
Hi, Dr. Levy. I'm glad to be here. I'm a professor of surgery and a thoracic surgeon at the Washington University in St. Louis.
I'm Dr. Mark Sosinski. I'm a thoracic medical oncologist and the executive medical director at the AdventHealth Cancer Institute in Orlando, Florida.
Great. So let's get started. Our next case, this is an 85-year-old former smoker, 20-pack year history of smoking with recurrent stage 4 disease. He is less than 1 year out after a right lower lobectomy and adjuvant chemotherapy for stage 3A carcinoma. His PD-L1 is 1%, and he has a positive KRAS G12D, that D mutation. And the questions are, what are the options here for early recurrence? So 85-year-old, very fit, presented with some left upper back pain. Performance status, he's got an ECOG 1. He walks 2 to 4 miles daily. His past medical history is consistent with hypertension, coronary artery disease, status post-CABG, that's stable. He's a former smoker, 20-pack year history, no known exposures. His family history, both his daughters had breast cancer. One was diagnosed in her early 40s and one in her early 50s. Because of this left upper back pain was being worked up, he ends up getting a CAT scan of the chest. And this is what we see on the CT of the chest, and I'll just turn it over to Dr. Bala to go over this.
Thank you, Dr. Levy. Basically, the single image shows that there's a 4-centimeter lesion in the left upper lobe, and there was nothing else, just this single spiculated lesion.
Great. So pretty straightforward here. So the workup, as Dr. Bala mentioned, this CAT scan shows a 4-centimeter left upper lobe mass. The biopsy is done that reveals adenocarcinoma. The PET scan only reveals uptake in the left upper lobe mass and some hilar nodes, but no mediastinal uptake. And the MRI of the brain is negative. So Dr. Puri, can you just walk us through how you approach these patients? He's 85, he's fit. He has a localized disease in the left upper lobe, maybe a hilar node on PET scan. Your surgical approach or workup in these types of patients?
As we approach this patient, one question I actually had for Dr. Bala is that, was there any evidence of chest wall involvement? Because this patient presents with chest pain, but on the single cut that I see, I did not really appreciate any chest wall involvement in that patient.
Yeah, Dr. Puri, I did not see any evidence of chest wall involvement or extension through the parietal pleura.
Very good, thank you. So we'll proceed with the assumption that we have no evidence of chest wall involvement in someone who has likely a T2, possible N1 left upper lobe lesion, and someone who's an otherwise healthy individual, although is an octogenarian. In this individual, obviously the decision-making for surgical resection is more straightforward if the patient were not an octogenarian. But that being said, that in and of itself does not preclude patients from undergoing surgical resection for stage 2 disease. With the presence of N1 disease, based on clinical imaging, one has to be very circumspect about disproving presence of N2 disease by preoperative mediastinal staging with either an EBUS or a mediastinoscopy before considering surgical resection for this individual. But if the mediastinum is pathologically negative, then one would consider, with a caveat of a somewhat elevated risk in the perioperative period, simply based on the patient's age, for someone with likely T2N1 left upper lobe non-small cell lung carcinoma. Most instances, one would perform an operation like this in a minimally invasive fashion. Particularly in octogenarians, there are retrospective studies and small case series which show that there is a significant benefit to trying to approach these lesions in a minimally invasive fashion for short-term postoperative outcomes. In addition, when you compare patients who undergo a thoracotomy versus a minimally invasive lung resection and their ability to get adjuvant therapy, this person with the assumption that he has N1 disease would be a definite consideration. The patients who undergo successful minimally invasive resections have a much higher likelihood of getting and completing the prescribed adjuvant chemotherapy. That would be my approach in a scenario like this.
Thank you, Dr. Puri. A great overview of how you approach these patients, octogenarian patient with these findings on a CAT scan and a negative PET and a negative brain MRI, critical for mediastinal staging. I think that's something that's often missed and something that needs to be done to prove that they're not N2 and declare nodal status. So this patient has looks like a left upper segmentectomy, and the final stage is a T2B-N1M0 invasive mucinous moderately differentiated adenocarcinoma. It's a stage 3A. The patient is in their 80s, and so they did not get cisplatin-based chemotherapy. I think Dr. Cieszynski and I would suggest cisplatin-based chemotherapy for most of our patients, and certainly we can have a conversation whether we substitute carboplatin at some point for these patients, but this patient gets 4 cycles of adjuvant carboplatin and pemetrexed. 9 months after chemotherapy, there is a concern of recurrence on surveillance imaging. The patient is entirely asymptomatic. So this is the next set of images are a CAT scan, and we'll go through the CAT scan first and then the PET scan findings as well. Dr. Bala.
So the 2 images from the CT show that there are bilateral nodules, which look very concerning for recurrent disease. They're present in both lungs and the right upper lobe, the right lower lobe, and in the left lower lobe. And so these are certainly quite concerning. And then I think, Dr. Levy, on the next slide with the PET CT, it also shows that there's uptake in these lesions as well, which is also confirms the suspicion that we're dealing with recurrence, and it's a bilateral recurrence.
Right. So as Dr. Bala mentioned, CAT scan and PET scan demonstrate recurrence bilaterally in the lung lesions. The MRI of the brain is negative for full staging. The patient does get a CT guided biopsy. The pathology is consistent again with mucinous adenocarcinoma. The PD-L1 is 1%, and the patient has a KRAS G12D mutation. So Dr. Cieszynski, treatment options at this point, 9 months ago, got carboplatin pemetrexed already. PD-L1, 1%, KRAS G12C clearly has recurrent systemic disease. What's your, how do you make a therapeutic decision here for a treatment for this patient?
Just to be clear, Dr. Levy, I want to be clear, it's G12D, not G12C, correct?
Yeah, and I think we can touch upon that right now and why that's important.
Yeah, there are, there's heterogeneity in KRAS mutations. The most common one we see in adenocarcinoma, and these occur in about 25 to 30% of adenocarcinoma cases. About 40 to 45%, if I remember correctly, are G12C. And we have 2 drugs that have recently been presented with some reasonably exciting data. I think it's mostly exciting because KRAS was the first molecular alteration described, and I believe it was somewhere in the late 1980s in lung cancer that this was described, and we've not been able to effectively target it. And we finally have a couple of drugs that do have activity, TKIs, oral TKIs that do have activity in this setting. So this I think will shortly be added to the list of oncogenic drivers with targeted therapies approved for them. However, they'll be approved just for the G12C subset. And I'm not aware of any specific TKIs, Dr. Levy, in the G12D population. So that's why I made the distinction. We don't have great data on this time since adjuvant therapy. We think longer the better. It wouldn't dissuade me from going, in a patient like this, going back to a chemo IO approach. I mean, one of the issues here in an 85-year-old is, timing of therapy. If these are small nodules, we just discovered them, we don't have a good sense of the cadence of progression. Could you do a short interval follow-up, 2 to 3 months, just to see the pace of how fast the lung nodules? When would he really need therapy? It might be a long time before he would become symptomatic from this sort of thing. So you might have that discussion. However, I probably would use kind of the Keynote 189 regimen in someone like this. So would be my preference. I would have a little bit of hesitation, because of the prior exposure recently to carboplatin, but it's been 7 months, so I wouldn't not pursue it.
Okay. Any thoughts on using the alternative regimen with like a cross-resistant drug, nab-pac, atezo?
Yeah, nab-paclitaxel, one of my favorite drugs. That would be, and there is some suggestion that maybe it's a better drug in the elderly. So I didn't think of that initially. Certainly, in the elderly patient, maybe that thought would cross my mind, given that many of these patients have borderline creatinine clearances, and pemetrexed does have a package label with regard to a certain creatinine clearance level for the safe use of that drug. So yeah, I think that would be a possibility. The one disadvantage there is that it's a weekly approach, different toxicity profile. So you'd have to have those considerations in there, but I don't think it would be a wrong choice, to be honest with you.
Okay. Let's trudge through some scenarios to try to get everyone involved here. Let's say that instead of having systemic recurrence, roughly 6 to 9 months after the surgery, there's a recurrence with a biopsy-proven 2-centimeter lesion in the contralateral lung. And I get a lot of different opinions on if this is just metastatic disease or if this is isolated progression. Dr. Puri, would you be interested in an octogenarian resecting a contralateral lesion 6 to 9 months after a left upper lobectomy or segmentectomy, whatever was done? Is this something that's on your radar, or is this to you a more surrogate that there are more things to come?
Dr. Levy, I think we would have probably have a very animated discussion in our local tumor board about a patient like this. But in general, the enthusiasm in the surgical community for tackling something like this in a contralateral setting with known ipsilateral N1 disease would be low. Because I agree, this is more of a marker of the biologic behavior of the disease rather than an opportunity to cure this patient.
Yeah. Dr. Curran, what if there was a local recurrence along the surgical site? Is this, and again, maybe Dr. Puri, we have to only go with what we have, which was the patient had a segmentectomy. Is this an opportunity for lobectomy? Is this more a radiation approach for a recurrence along the prior surgery?
Yeah, I mean, it's my view, it could be either or. Really depends on the fitness of the patient, the enthusiasm of the surgical team to go in a second time on an octogenarian, as well as the anatomy of the recurrence with respect to a radiotherapeutic approach. I mean, it'd be great if it was focused enough that it could be a stereotactic short course. And I say that's advantageous just because of patient time, but I also believe the dose fractionation of stereotactic radiation in general has a higher local control than standard fractionate treatment. So really, as you say, it's both an anatomical and a patient fitness decision, and certainly speaks to the value of multidisciplinary coordination of care of patients like this.
I completely agree with Dr. Karan's assessment. The one thing that I would add to what we just discussed about is that this patient had prior coronary artery bypass grafting. In the majority of patients in today's day and age, there would be a left internal mammary artery graft that would be running in a left-sided paramediastinal location, likely in the location where the staple line is. And the staple lines are typically often very adherent to surrounding structures in the mediastinum. So in that setting, there would be at least some potential risk to that left internal mammary artery graft, which in most individuals is open and often is the critical blood supply to at-risk myocardium. So that would be an important anatomic consideration from a surgical perspective. Dr. Karan, would that be a consideration from a radiation therapeutic perspective too?
Well, it'd be really great for the radiation oncologist to go over with the thoracic surgeon the anatomy of that. So ideally, what it should be, it'd be sort of an exclusion target definition. Let's keep the dose there as low as possible. Don't necessarily say I don't think we'd have to give no dose, but we want to avoid a high dose to that area.
Great input from both of you. I think I already know the answer to this, but Dr. Szynski, let's say there's a systemic recurrence with a PD-L1 90. Patient received 4 cycles of chemotherapy, finished 9 months ago. Is this a slam dunk decision?
Well, yeah, assuming that it's along the lines of what we saw in this patient, very low volume disease, the patient's asymptomatic. In an 85-year-old with a 90% PD-L1, it's very attractive because of the side effect profile to use monotherapy in this setting. You'd have your choice, I think, between pembro and atezolizumab in this setting. I think that would be a very attractive approach, assuming the systemic recurrences like we've been talking about here, isolated to the lung, relatively minimal asymptomatic disease.
Okay. And then lastly, the toughest one, let's say the patient had resection and received the adjuvant carboplatin for 4 cycles, and then 9 months later has an isolated brain lesion. I'm going to say it's 1 centimeter. Dr. Kieran, we talked about this before. I assume this is a fair game for radiation approaches.
Yeah, 1 centimeter lesions could certainly get a stereotactic approach, absolutely.
Dr. Szynski, let's say Dr. Kieran recommends radiation. In my mind, this patient the chemotherapy didn't do its job. If Dr. Kieran radiates the lesion and there's no disease anywhere else, would you hold off on treatment or would you start a treatment right away?
No, I would hold off on treatment. Again, the patient did have treatment. The treatment wasn't necessarily effective in an 85-year-old. If you could establish local regional control with radiotherapy in the brain lesion, I would follow the patient closely with the typical surveillance protocol. I'm not in a hurry to rush into systemic therapy before you have to, at this point, one of our radiation oncologists at the University of North Carolina would always say, don't go looking for trouble till trouble comes looking for you. So, that's
to be Julian.
Actually, it was Dr. Halley that used to say that, Dr. Curry.
How often would you scan this patient if you're not looking for trouble? How often do you post radiation to the brain with no evidence of disease, would you institute a surveillance imaging strategy?
Well, our radiation oncologists have their standard follow-up post gamma knife or whatever the technology you want to use there. So it's typically every 3 months or so. I think for the first year, I would want to keep a close eye with a Q3 month or scan if the patient had any new symptoms, that sort of thing. That would be my approach.
Okay.
And I would strongly advise against the use of PET scans in this setting.
Yeah. I think point well taken. Because why? The sense that you seek and you shall find?
Well, yeah, I mean, I'm satisfied if we're following stuff in the lung. I'll concede to Dr. Bala, but most of our assessment of cancers, if you look at RECIST criteria, it's measurement of tumors. It's anatomic criteria. And when I look at a CT scan portion of the PET scan, it's not a very high quality CT scan if you look at dedicated CT scans. So, patients will often ask for a PET scan and I'll kid around with them. I go, if you just rearrange the first 2 letters of nuclear, you get unclear medicine. And so that's I don't want to be practicing unclear medicine. So now, but I will say to them that PET is a great tool. And if there's a question that is best answered by PET scan, then it should be done. But in terms, I see so many second opinions in which PET scans are being done routinely, and then patients come with reports that their SUV went from 7.8 to 9.1. What does that mean? I don't know what that means. So I try to avoid that sort of interaction with patients by just doing a dedicated anatomic CT scan, and then use PET judiciously when I have a question I think is best answered by PET.
Yeah. This concludes the case. I want to thank everyone again for layering in their insights and some of the gems, take homes from this case. I really appreciate everyone's participation in discussing this patient. Thanks so much.